السلام عليكم الزميلات والزملاء الأعزاء. أنا مينا عازر. أنا استشاري جراحة فيسرال سيرجري في مستشفى نوردن في شمال ألمانيا. أنا خريج جامعة المنصورة دفعة 2007. والحقيقة يعني ليا الشرف إن أنا جمعية جسر النهاردة دعتني إن أنا أتكلم مع حضراتكم، ده يعني شرف كبير ليا. وبحب أشكر الجمعية جدا على الفكرة الممتازة ديت، ويا رب دايما التعاون دوت يفضل مستمر على طول. النهارده احنا هنتكلم عن الكولوريكتال كارسينوما. هنبدأ الأول نتكلم عن الاتيولوجي، الريسك فاكتورز، الكلاسيفيكيشنز بتاع التيومرز. بعد كده هنبدأ نتكلم عن التريتمنت، سواء السيرجيكال تريتمنت او الالجوريزم بتاع التريتمنت عامة according to the staging. المحاضرة هتكون بالانجلش علشان يعني برضو انا المفروض نتعاون بالاطباء المصريين والاطباء الالمان، فالانجلش هو اللغة المشتركة بين الاثنين. انا بس عايز اعتذر من حضراتكم ان المحاضره مسجله، لان انا للاسف في يوم المحاضره ده عندي دينست او نبطشي فللاسف ما قدرتش اكون معاكم لايف، بس ان شاء الله تتعوض في المرات الجايه. الف الف شكر ونبدا.
But before we dive into the depth, I would like to emphasize the importance of the differentiation between rectum and colon from a surgical point of view. While colon and rectal carcinoma appears from the histopathological point of view almost identical, it's very important to differentiate between them as early as possible in the diagnostic phase, because each of them will undergo a markedly different therapeutic pathway. A rectal carcinoma or a tumor is defined as a lesion within 16 centimeters from the anal verge measured with a rigid rectoscope. Here, a rigid rectoscope is a crucial part of the definition because a flexible coloscope can give us sometimes false measurement. Any lesion proximal to 16 centimeters from the anal verge up to the ileocecal valve is termed a colon carcinoma. Rectal tumors represent 37% of all colorectal tumors, while sigmoid tumors are in the second place with 27%, and in the third place is the cecal tumors with 14%. Now we will talk about the risk factors of colorectal carcinoma. First of all, the acquired risk factors are smoking, excessive alcohol consumption, obesity, low fiber or fat-rich diet. Genetic risk factors include inflammatory bowel disease such as ulcerative colitis, in which the lifelong probability of acquiring a colorectal carcinoma is about 10%, and to lesser extent, Crohn's disease. Another pathway of formation of colorectal carcinoma, which can be considered the most common pathway, is the adenoma carcinoma sequence, which means formation of a malignant tumor on top a pre-existing benign tumor, which is a colorectal polyp. Here we must differentiate between three types of colorectal polyps, which is adenomatous polyp, adenovellous polyp, and vellus polyp, which is the most common precancerous lesion. This formation is due to a mutation of the APC gene and P53 gene. Another genetic predisposing factor is the familial adenomatous polyposis syndrome, which is characterized by the presence of more than 100 polyps all over the colon. Here, the risk of the colorectal carcinoma is 100%. There is another type of the familial adenomatous polyposis, which is the attenuated type, in which we can see less than 100 polyps in the colon, which is also a high risk for colorectal carcinoma. The last variation is the hereditary non-polyposis colorectal carcinoma, also known as the Lynch syndrome. Lynch syndrome carcinoma is usually associated with other carcinomas like ovary and endometrial carcinoma, stomach carcinoma, urethral carcinoma, and rarely skin and brain carcinomas. This familial type of colorectal carcinoma represents about 3% of all colorectal carcinomas. A Lynch syndrome or a familial colorectal carcinoma is suspected when the Amsterdam second criteria are met. When at least 3 patients with a Lynch-related carcinoma are diagnosed, one of them is a first degree relative to the other two in 2 successive generations, like a father and a son, and at least one of them was younger than 50 years old at the first diagnosis. Also, FAB must be excluded, and all tumors must be histologically confirmed. Another widely used criteria to diagnose the Lynch syndrome is the Bethesda criteria. When met, the specimen postoperatively must be sent to genetic investigation. The diagnostic test is the MSI or the microsatellite instability. The Bethesda criteria includes a colorectal carcinoma at age younger than 50 years old, multiple Lynch syndrome related carcinoma, meta or the synchronous, microscopic or the histologically characteristic of the microsatellite instability, one first degree relative with Lynch syndrome related carcinoma younger as 50 years old, two first or second degree relatives with Lynch related carcinoma at any age. Here we can notice that this criteria is more post-operative criteria in contrary to the Amsterdam criteria, which is history based. When a Lynch syndrome is established through the previous criteria in a patient, all the first degree relatives of this patient should undergo surveillance, which means colonoscopy every 2 years, starting from age 5 years younger as the first diagnosis of the patient. In this particular cohort of patients, it was suggested that aspirin 300 mg daily could have a protective effect against the formation of colorectal carcinoma in families affected by Lynch syndrome. Prevention of the colorectal carcinoma depends on the lifestyle modifications such as quitting smoking and alcohol consumption, healthy high fiber diet. The second pillar of prevention is the early detection, which includes a yearly occult blood in stool at the age of 50, when positive a colonoscopy must follow, or a colonoscopy at the age of 55 when positive follow-up is recommended, but when negative it must be repeated in 10 years. This was according to the German guidelines, which is somehow widely accepted. Symptoms of colorectal carcinoma depends on the site of the carcinoma. For example, for rectal and descending colon carcinoma, the most common feature is altered bowel habits or bleeding per rectum. But for the right-sided lesions like cecal carcinoma, the most common features are anemia, fatigue, anorexia, and paraneoplastic syndrome. This could be explained by the fact that descending colon and the rectum are relatively narrower lesions with high intraluminal pressure, which can be easily obstructed or affected by a growing lesion. While on the other hand, the cecum and the ascending colon are capacious organ in which a luminal lesion rarely causes a local obstruction, and the more common features is the general symptoms of tumors like anemia and paraneoplastic syndrome. According to the British guidelines, high-risk criteria of colorectal carcinoma includes altered bowel habits and bleeding per rectum for 6 weeks, altered bowel habits for 6 weeks at age over 60 years old, bleeding per rectum at any age without anal symptoms such as pain, itching, hemorrhoids, and discomfort, palpable right abdominal mass or rectal mass, iron deficiency anemia which is otherwise unexplained. Now we will move to the classification of the colorectal carcinoma based on histological features. This classification is based on the TNM 8th edition. As we see here in this diagram, this is a cross-section of the colonic wall formed of mucosa, muscularis mucosa, submucosa, musculosa propria, pericolic fat, and serosa. A superficial tumor, which is only confined to the mucosal layer, is called carcinoma in situ, or TIS. A second stage is the T1 tumor, which invades the muscularis mucosa and reaches the submucosal layer. Reaching the submucosa is a landmark in the natural history of any tumor because this layer is rich with lymphatic supply and the probability of lymphatic spread is dramatically increased. A T2 tumor penetrates the submucosa and invades the muscularis propria, while the T3 tumor reaches the muscularis propria and reaches the pericolic fat. A T4 tumor perforates the serosa. T4A includes a perforated tumor without invasion of adjacent organs. T4B tumor invades adjacent organs like spleen or kidneys. Now we will move to the N classification. Here we can see the marginal artery supplied by the vasorector coming from the colic arteries. N0 means no lymphatic invasion. N1A means 1 lymph node in the pericolic area. N1B, 2 to 3 lymph nodes in the pericolic areas. N1C, where there's no affected lymph nodes, but there's a presence of isolated tumor in the lymph drainage area of the tumor. N2A, 4 to 6 lymph nodes. N2B is 7 or more affected lymph nodes in the drainage area of the tumor. Here we must notice that in order to perform an adequate end-stage estimation, a minimum of 12 lymph nodes must be harvested during the OP. Only regional lymph nodes counts along the marginal artery or the mesocolon or the mesenterium. Other than that, lymph nodes invasion is considered to be distant metastasis or M1A stage, which is also defined as the presence of distant metastasis in one organ other than peritoneal nodules. M1B, 2 organs, and M1C is the presence of peritoneal nodules. The UICC staging system is also based on the TNM classification, where stage 0 is carcinoma in situ, stage 1 and 2 are carcinoma without lymph nodes invasion, stage 3 is when the lymph nodes invasion appears, and stage 4 is a distant metastasis stage, which also considered as a systemic disease. A simplified version of this staging system is the Duke's staging system, in which stage A is the carcinoma in situ and carcinoma confined to the muscular propria, stage 0 and 1. Stage B is without lymph nodes invasion but penetrating the muscular propria, and stage C with lymph nodes invasion. Stage D is the distant metastasis. This staging system is widely known and used in the United Kingdom. We will talk about the management of colon carcinoma, starting with the general rules of therapeutic approaches. The choice of the therapeutic pathway depends on the stage of the disease. For stages 1, 2, and 3, the treatment of choice is surgical resection with or without adjuvant chemotherapy. Stage 4 represents a metastasized tumor. It was considered before an advanced stage of tumor beyond the reach of curative approaches. But now we can see in modern guidelines, resectable metastasis can be also removed. Then adjuvant chemotherapy can be given with a good impact on longevity. But this approach is up till now only reserved for relative early cases with good general conditions. Other than that, advanced cases can be treated with palliative options, in which palliative resection remains the best palliative option because the patient will develop, if not treated, a fatal intestinal obstruction sooner or later, which will in turn require operative management. It's wise also to perform the operation on elective basis other than in the middle of the night. Last options include palliative chemotherapy and best supportive cares. The change of treatment philosophy can be noticed here in considering the resectable metastasis in a relative healthy patient among the potentially curative approaches. Now we will talk about the principles of surgical resection. The first principle is how to determine the extent of resection. This depends on the location of the tumor itself in relation to the feeding vessels of this part of the colon. This is important for 2 reasons. Number 1, removing of a part of the colon with its feeding vessels ensures that the removal of the potentially infiltrated lymph nodes, which dramatically affect the rate of recurrence. Number 2, following feeding vessels rule ensures a good blood supply of the remaining part, which is crucial for a safe anastomosis. Keeping these rules in mind, we can know now that a sound removal of tumors in cecum, ascending colon, or hepatic flexure requires removal of the part of the colon fed by the ileocolic artery, right colic artery, and the right branch of the middle colic artery. This means removal of cecum, ascending colon, hepatic flexure, and about 1/3 of the transverse colon. This is known as the right hemicolectomy. For sigmoid tumors, Resection of sigmoid colon along with the sigmoidal branches of the inferior mesenteric artery is performed. Tumors of the descending colon are treated with the removal of the sigmoid colon, descending colon, splenic flexure, and the distal 1/3 of the transverse colon, along with the central ligation of the inferior mesenteric artery, which is known as the high thigh, and the left branch of the middle colic artery. In tumors of the transverse colon, an extended right hemicolectomy is performed, which follows the same resection requirements of the right hemicolectomy, in addition to removal of the whole transverse colon and splenic flexure, along with the left branch of the middle colic artery. Lastly, the tumors of the splenic flexure are treated with a partial hemicolectomy procedure, which requires the removal of the splenic flexure along with the distal third of the transverse colon as well as the proximal third of the descending colon. The feeding vessels are the left branch of the middle colic artery and the ascending branch of the left colic artery. To summarize, the 5 main procedures are the right hemicolectomy, the extended right hemicolectomy, sigmoidectomy, left hemicolectomy, partial left hemicolectomy. The second rule is the central ligation of the vascular pedicle as close as possible to its origin. The third rule addresses the lymph node harvest. At least 12 lymph nodes should be harvested in the specimen in order to evaluate the end stage of the tumor. This includes the paracolic lymph nodes, mesenterical lymph nodes, and central lymph nodes, along with any suspicious lymph nodes. The fourth rule is the mucosal safety margin, which should be at least 5 cm between the tumor and the resection line, preferably 10 cm when possible. Number 5, an untouched technique should be used with number 6, which is the M-block resection to avoid local tumor spread or peritoneal seeding. Number 7 is approach. Laparoscopic and open approaches are both equivalent and should be decided according to the surgeon's expertise. The last principle is following the CME, or the complete mesocolic excision, which is in a way a summary of all the previous principles. It includes dissecting along the embryonal plane of the mesocolon, maximal lymph node harvesting, and central ligation of the feeding blood vessels. Now let's move to the detailed algorithm of management of colon carcinoma according to the most recent American and European guidelines. As we said before, the therapeutic pathway depends to a great extent on the initial stage of the tumor. Stages 1, 2, and 3 shares the initial step of operative resection with curative intention according to the previous principle of oncological surgery in colon carcinoma. Stage 1 requires only follow-up postoperatively, while Stage 2 must be divided according to the presence of risk factors. Here, by risk factors, we mean factors that can indicate the presence of undetected lymph node infiltration, which renders the staging of the tumor from Stage 2 to Stage 3. These factors are a T4 tumor, a tumor perforation preoperatively, an intraoperative tumor dissection, emergency operations, less than 12 lymph nodes harvested in the specimen, the presence of lymph vessels infiltration, L1, or V1, which is veins infiltrations. In the absence of these risk factors, the microsatellite stability should be evaluated in the pathological report. Microsatellite stable tumors have worse prognosis but benefit from chemotherapy, so adjuvant chemotherapy is justified. On the other hand, microsatellite unstable tumors have a better prognosis and don't benefit much from the chemotherapy, which fails to justify the adjuvant chemotherapy. The presence of risk factors, which means a potential Stage 3 or an evidence Stage 3 by positive nodal stage, both requires postoperative chemotherapy. In a nutshell, adjuvant chemotherapy is required in Stage 3, Stage 2 with risk factors of becoming Stage 3, or microsatellite stable tumors of Stage 2 without risk factors. Regarding Stage 4, which includes distant metastasis, here we must differentiate between Stage 4 with a resectable metastasis of lung or liver and primary irresectable metastasis, as well as metastasis elsewhere like peritoneal metastasis, which is a stage 4C. In resectable metastasis of lung and liver, it can be managed either by primary resection with adjuvant chemotherapy or 3 months chemotherapy, then resection, then adjuvant chemotherapy. On the other hand, primary irresectable metastasis does not mean giving up the hope of a potential curative management. In patients with good general condition and willing to undergo extensive therapy, a neoadjuvant chemotherapy as an attempt to downstaging can be given. After evaluation, when the tumor is rendered resectable, the patient passes to the limb of operation and adjuvant chemotherapy. When not, the patient passes to the palliative limb with palliative chemotherapy or best supportive care. So, take-home messages are: adjuvant chemotherapy depends on the lymph node metastasis, evidence, or potential. Resectable metastases are potentially curable. Neoadjuvant therapy is only of benefit in potentially resectable metastases. The previous statements raise an important question, which is how to evaluate a stage 4 tumor to be resectable or not. Careful selection of patients in this stage is very important, as the patient will undergo a complex therapeutic course with a risky operation. So this decision must be good justified and adds a remarkable benefit regarding the expected life duration and quality. A good tool to use in this regard is the Fong criteria, which are N positive tumor at the first diagnosis, stage 2 or 3, when addressing a metachronous metastasis, less than 12 months interval between the primary resection of the tumor and the diagnosis of the metastasis, preoperative carcinoembryonic antigen more than 200 nanogram per milliliter, and two more factors regarding the liver metastasis: more than one liver foci in the preoperative imaging, and the size of the largest liver focus is more than 5 cm in the preoperative imaging. Each of the previous are assigned 1 point, and a total score of 0 represents a low risk of recurrence in the next 5 years. Score of 1 to 2 represents an intermediate risk, and 3 to 5 is a high risk of recurrence in the next 5 years. A low Fong score, and in turn a low risk of recurrence of metastasis, should be regarded as a favoring factor of pursuing a more aggressive therapeutic course. The next step should be the evaluation of the local resectability of the metastasis tumor itself, as well as the readiness of the patient to undergo such an aggressive treatment. The patient should be free of other severe illness, ASA score of 1 to 2, with performance status or Eastern Cooperative Oncology Group score from 0 to 2. This means the patient can at least walk and take care of his basic needs. No other resectable metastasis elsewhere. Local R0 resections is possible without impairing liver or lung functions. This means for liver, no liver cirrhosis or only a child A compensated liver disease. More than 30% future functional liver remnant is possible. Possible safety margin from the central vessels of the liver. For lung, enough postoperative residual lung volume is possible, and no technical difficulties of R0 resection. At last, what is the outcomes after colon resection for tumors, or evaluation of the surgical procedures? Intraoperative, we must think of the oncological surgical principle. Did we perform a sound oncological procedure with TME or CME principle? Did any intraoperative complications occur, like ureter injury, major bleeding, or difficult anastomosis? When so, have we made an ileostomy to protect the anastomosis? Postoperative period. Are any complications occurred in the postoperative period? For example, leakage of the anastomosis, wound in complications, surgical site infection, General complications like pneumonia. Was the patient discharged in a good shape, capable of living a relative healthy and enjoyable life? And now to the pathology report. We should check the confirmation of the tumor through checking the type and the grading of the tumor. Confirmation of sound resection techniques. This appears in R0 resection, more than 12 lymph nodes harvested, and safety margin of at least 5 centimeter is documented. Lastly, the determinant of further therapy of the patients, the PTNM staging, L and V staging, microsatellite stability or instability.